Morning to all. Today I am presenting the topic on effect of Remdesivir versus standard care on clinical status at 11 days in patients with moderate COVID-19. The article is published from JAMA in September 2020 and my moderator is Dr. Shoaib sir. Coming to introduction, coronavirus 2019 as of August 2020 resulted in more than 1,63,000 deaths in the United States and more than 7,30,000 worldwide. And many infected people are asymptomatic or experience mild symptoms and recover without medical intervention. However, older people and those with comorbid hypertension, diabetes, obesity, and heart diseases are at higher risk of life threatening illness. And remdesivir is a nucleotide prodrug whose active metabolite inhibits viral RNA dependent RNA polymerase that play a key role in the replication of a broad range of viruses, including coronavirus. Importance of the study: Remdesivir demonstrated clinical benefit in a placebo-controlled trial in patients with severe coronavirus disease, but its effects in patients with moderate disease is unknown, and the objective to determine the efficacy of 5 or 10 days of remdesivir treatment compared with the standard care on clinical status on day 11 after initiation of treatment. Methods: it's a randomized open-label trial of hospitalized patients with confirmed severe acute respiratory syndrome, that is coronavirus 2, SARS-CoV-2 infection, and moderate COVID-19 pneumonia, characterized by pulmonary infiltrates and room air oxygen saturation more than 94%. Enrolled from March 15 through April 18, 2020 at 105 hospitals in the United States, Europe, and Asia. The date of final follow-up was May 20, 2020. Interventions: patients were enrolled at 105 hospitals in the United States, Europe, and Asia between March 15, 2020 and April 18, 2020. Patients were randomized in a 1:1:1 ratio to receive a 10-day course of remdesivir, a 5-day course of remdesivir, or standard care. Remdesivir was dosed intravenously at 200 mg on day 1, followed by 100 mg per day once a day for subsequent days, infused over 30 to 60 minutes. And remdesivir treatment was to be discontinued in any patient experiencing severe elevations in liver enzymes or decrease in estimated creatinine clearance to less than 30 ml per minute. Patients who had sufficiently improved in the judgment of the investigator could be discharged from the hospital before finishing their assigned course of treatment. Clinical and laboratory monitoring. The primary assessments included physical examination, respiratory status, that is respiratory rate, type of oxygen, blood oxygen saturation, and radiographic findings, adverse events, and concomitant medications. On study days 1, 3, 5, 8, 10, and 14, blood samples were obtained for measurement of blood cell count, serum creatinine, glucose, total bilirubin, and liver transaminases. Site investigators assessed clinical status daily from day 1 through day 14 of hospital discharge on a 7-point ordinary scale. 7-point ordinary scale consists of the following categories. First one, death. Second one, hospitalized patients requiring invasive mechanical ventilation or extracorporeal membrane oxygenation. Third one, hospitalized patients requiring non-invasive ventilation or use of high flow oxygen devices. Fourth one, hospitalized patients requiring low flow supplemental oxygen. Fifth one, hospitalized patients not requiring supplemental oxygen but requiring ongoing medical care related or not to COVID-19. Sixth one, hospitalized patients not requiring supplemental oxygen or ongoing medical care. And seventh one is not hospitalized patients. Endpoints. The primary efficacy endpoint was the distribution of clinical status assessed on the 7-point ordinal scale on study day 11. If remdesivir treatment improves outcomes, the distribution of scores among patients who received remdesivir should shift more towards the higher values of the scale than the distribution of scores among patients who received standard care. The secondary endpoint was the proportion of the patients with adverse events throughout the duration of the study. Pre-specified exploratory endpoints were time to recovery, that is improvement from baseline score of 2 to 5 to a score of 6 or 7 or from a baseline score of 6 to a score of 7. Time to modified recovery, that is improvement from baseline score of 2 to 4 to a score of 5 to 7, improvement from a baseline score of 5 to a score of 6 to 7, or from a score of 6 to a score of 7. Time to clinical improvement, that is more than or equal to 2-point improvement from baseline on the 7-point ordinal scale. Time to 1 point or larger improvement. Time to discontinuation of oxygen support or other exploratory endpoints were duration of hospitalization, duration of different modes of oxygen support, and all-cause mortality. Statistical analysis. We calculated that 600 patients, that is 200 in each group, would provide greater than 85% power to detect an odds ratio of 1.8 for each remdesivir group versus standard group. An odds ratio greater than 1 indicates changes in clinical status across all categories towards category 7 for the remdesivir group versus standard group. For the primary efficacy endpoint, each remdesivir group was compared with the standard care group at a two-sided, that is alpha equal to 0.25. For the secondary endpoint of proportion of patients with adverse events throughout the duration of the study, comparison between each remdesivir group and the standard group were performed using Fisher-Exact test. All-cause mortality was estimated using the Kaplan-Meier product limit method with all the available data. Duration of oxygen therapy and hospitalization were summarized and compared between groups using the Wilcoxon-Rank-Sum test. To understand if the open-label design and assigned duration of treatment had an effect on hospital discharge, they calculated the rates of discharge in each group over time. Results. Patients in the three groups were balanced in their demographics and disease characteristics. Overall, 56% of the patients had cardiovascular disease, 42% had hypertension, and 40% had diabetes. 12% of the patients in 10-day remdesivir group, 16% in the 5-day remdesivir group, and 19% in the standard care group used supplemental oxygen in the day 1 because of deteriorating clinical status or due to breathing discomfort. Of the 191 patients in the 5-day remdesivir group, 145 completed the assigned treatment duration. Reason for discontinuation of treatment included hospital discharge, withdrawal of consent, and adverse events. This is the diagram showing the participant flow in a randomized clinical trial of remdesivir versus standard care in patients with moderate COVID-19. 612 patients were screened, and of which 16 of them were excluded. Remaining of the remaining 596 patients, 197, 199, and 200 were assigned to 10-day remdesivir group, 5-day remdesivir group, and standard care group. And we can see that at the end of the study, 193 were included in the primary analysis, 191 in the primary analysis of 5-day remdesivir group, and 200 were included in the primary analysis of standard care group. Table 1. This is a diagram showing demographics and the baseline disease characteristics. Here we can see that the demographics are matching in the all the three groups. That is, the mean age was 56 in 10-day remdesivir group, in the 5-day remdesivir it was 58, and 57 in the standard care group. Similarly, sex, that is male and female pair, were in equal proportion. And also the white, the black, the Asian, and other categories are also in almost equal proportion in all the three groups. And also, in case of body mass index, also is matching in the three groups. That is 28 in the 10-day remdesivir group, 27 in the 5-day remdesivir group, and 27 in the standard care group. And other coexisting conditions like cardiovascular diseases, hypertension, diabetes, asthma is also on an equal proportion in all the three groups. That is 5-day, 10-day, and the standard care group. And also in some of the groups they also used steroids, HCQs, lopinavir, tocilizumab, and azithromycin. And also we can see that the usage of these in patients were also in a equal proportion in all the three groups. That is, for example, in the steroid group we can see that 29 were included in the 10-day remdesivir group, 33 in the 5-day remdesivir group, and 38 in the standard care group. Of the 193 patients in the 10-day remdesivir group, 73 completed the assigned treatment duration. Reasons for discontinuation included hospital discharge, that is 98 patients, adverse events, that is 8 patients, and withdrawal of consent, 8 patients. Efficacy or primary endpoint. On the day 11, patients randomized to the 5-day remdesivir group had significantly higher odds of a better clinical status on the 7-point ordinal scale compared with those randomized to the standard care. The difference in the clinical status distribution on the day 11 between the 10-day remdesivir and the standard care group was not statistically significant, and the p-value is only 0.18. Next is coming to exploratory efficacy endpoints. There were no significant difference between the 5-day or the 10-day remdesivir groups and the standard care for any of the following exploratory endpoints. That is, time to 2 point or greater improvement in clinical status, time to 1 point or greater improvement in clinical status, time to recovery, time to modified recovery, time to discontinuation of oxygen support, and there were no significant differences between the remdesivir and the standard care groups in the duration of oxygen therapy or hospitalization. By day 14, clinical status of the 5th day and 10-day remdesivir groups was statistically significantly different than that of the standard care group. By day 28, clinical status remained significantly different in the 10-day remdesivir group compared with the standard care. Coming to adverse events, that is secondary endpoints, adverse events were experienced by 51% of the patients in the 5-day group, 59% in the 10-day group, and 47% in the standard care group. The differences in the percentage between the 5-day remdesivir group and the standard care was not statistically significant, but the difference between the 10-day remdesivir group and the standard care was significant. This is table 2. This is coming to the clinical outcomes. We can see that in case of 10-day group, 5-day remdesivir group, and the standard care, the number of people who succumb to death were 2, 0, and 4. And also in case of hospitalized patients requiring invasive mechanical ventilation or extracorporeal membrane oxygenation was 1 in the 10-day remdesivir group, 5 0 in the 5-day remdesivir group, and 4 in the standard care group. Similarly, in the other case also we can see that the hospitalized patients not requiring supplemental oxygen or medical care, it was 9 in the 10-day remdesivir group, 7 in the 5-day remdesivir group, and 8 in the standard care group. And the p-value, you can see that the p-value is significant in the 5-day remdesivir group. In the 10-day remdesivir group, the p-value is only 0.18, whereas in the 5-day group, the p-value comes to 0.02. That is more significant as compared to the 10-day remdesivir group. Coming to the clinical improvement, and we can see that day 5, 7, and 11, the difference in the percentage versus the standard care at day 11, it was 4.8 in the 10-day remdesivir group, whereas it is 9.7 in the 5-day remdesivir group. That is more than the 10-day remdesivir group. And also difference in percentage versus standard care at day 11 in case of recovery at day 5, 7, and 11, it is seen that it is 4.4 in case of 10-day remdesivir group, 9.8 in the 5-day remdesivir group. That too also shows that the difference in percentage is more in the 5-day remdesivir group compared to the 10-day remdesivir group when comparing with the standard care. Also, we can see that at the end of the study, towards the day 28, almost the same number of patients we can see in the 10-day, 5-day, and the standard care groups. That is 178, 175, and 170. This is a table showing adverse event summary. And in case of death, we can see that in the 10-day remdesivir it was 3, in the 5-day remdesivir it was 2, whereas in the standard care it was 4. And also adverse event any grade more than equal to 3 adverse events, it was 24 in the 10-day remdesivir group, 5-day remdesivir group it was 20, and the standard care it was 24. Yes, of also adverse events occurring in more than 5% of participants in any treatment group, that is nausea, diarrhea, hypokalemia, headache. These are almost in an equal proportion in all the 3 groups. And also coming to laboratory abnormalities, that is any grade 3 or grade 4 abnormalities, also we can see that there is no significant differences between the 5-day or the 10-day remdesivir group. For example, another example is in case of alanine transaminase increase, that is grade 3 or grade 4 increase, we can see that it is 6 out of 177 in a 10-day remdesivir group, 4 out of 179 in 5-day remdesivir group, and 71 out of 182 in standard care group. And next is creatine clearance decrease. And grade 3, in case of grade 3 creatine clearance decrease, we can see that it was 7 out of 176 patients in 10-day remdesivir group, 4 out of 178 in 5-day remdesivir group, and 9 out of 183 in standard care group. The adverse events that were common in the remdesivir groups than in the standard care group include nausea, hypokalemia, and headache. Serious adverse events were less common in the remdesivir group, that is 5% in the both groups, than in the standard care group. Coming to discussion. In this trial of patients with moderate COVID-19 pneumonia, those who were randomized to remdesivir treatment for up to 5 days had significantly higher odds of having a better clinical status than those receiving standard care. The difference in the distribution of clinical status on day 11 between the 10-day remdesivir and the standard care groups was not significant. However, when the outcomes at 14 days and 28 days were evaluated, similar distributions of clinical status were observed between patients in the remdesivir groups. It possibly points to the differences compared with the standard care. Future trials should consider studying individual severity strata, incorporating further clarification and refinements in the definition. Factors that contribute to patients progressing to severe and critical COVID-19 remain to be elucidated. The risk of rapid disease progression described to date points to the potential benefit of earlier intervention with an effective antiviral. Coming to conclusion, among patients with moderate COVID-19, those randomized to a 10-day course of remdesivir did not have a statistically significant differences in clinical status compared with the standard care at 11 days after initiation of treatment. Patients randomized to a 5-day course of remdesivir had a statistically significant difference in clinical status compared with the standard care, but the difference was of uncertain clinical importance. Thank you.